Hello, Dr. Awar again. I'll give you a brief lecture on malaria, which is caused by Plasmodium species. Now, human malaria, and I have told you before that each live organism in nature has got its own malaria. So the human malaria is caused by 4 species: Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, and Plasmodium malariae. With the note that Plasmodium falciparum is the most common of the malarial parasites, especially in tropical areas. It is the most dangerous and also the most resistant to chloroquine. Now, Plasmodium knowlesi occurs in monkeys and rarely in humans in localized areas in Southeast Asia. The story of this Plasmodium knowlesi is that in the Pacific area around Malaysia, Indonesia, and that areas, in the tropical forests, because people are going for deforestation, constructing roads in those forests, as well as living places. Then people are coming in contact with the mosquito, which is the vector of the simian malaria from monkeys. So people have got to be infected, particularly with this Plasmodium knowlesi. Apparently, you know that biology, apparently it was able to survive in humans and produce the infection, and now it is established as Plasmodium knowlesi that may produce infection in humans. Just a little story is that in one of our Peace Corps in the south, يعني بجندي من جنود الأمم المتحدة, he donated blood. An old lady received that blood and he was fine, he was healthy, he was not febrile and so at the time of donation. And then that lady came down with severe malaria that was eventually Plasmodium knowlesi. Okay, so we have had the experience with one severe case of Plasmodium knowlesi and maybe other cases. All right, you have seen this map before, and as you can see in the lower map, actually, there are many areas in tropical countries which are all infested with malaria. And if you take in South America, the peripheries of the Amazon basin and different countries there may have high or low prevalence of malaria. In sub-Saharan Africa, it is fairly high, except that in some areas there which are colored in pink, there is a little bit of malaria in there, but there isn't much of people in those areas. Those are deserted areas, the Sahara. صحراء الكبرى بشمال أفريقيا. And then when we come to Southeast Asia and the Pacific region, there are regions in there which are high endemic or with less endemicity. One has to check on that, and we have to check on that whenever a traveler is going into that area to give them the right prophylaxis. Okay, importance of malaria, especially Plasmodium falciparum. It's the widest spread tropical disease, the heaviest mortality, mostly in children between the ages of 2 and 5 years in the tropics, which accounts for about 1 million deaths per year. It is common and serious morbidity, mainly manifesting as high fever, anemia, central nervous system, and other complications that we shall come to discuss briefly. It's especially serious complications in pregnancy, a threat to travelers to the tropics, and it could be the most important tropical disease. Okay, so it's a cause for mortality for African children, for South American children in the endemic areas, in the highly endemic areas there. Okay, this is the female Anopheles mosquito that is getting a blood meal, and this is exactly what happens at getting a blood meal. It gets engorged with the blood until it starts dribbling from the other end, actually, because it needs to get once for all a highly nutritious blood meal, especially nutritious for its ova within its uterus. Okay, the life cycle, as you can see here, starting from 1 and going up to 2, 3, or down to 2, 3, 4, and so. The Anopheles mosquito comes to bite man. If it is infected, it will deposit the sporozoites, which will be rapidly taken up by the Kupffer cells in the liver, by the macrophages of the liver, and this is a process that takes about 15 to 20 minutes only. So the sporozoites escape from the immune response and they go hide themselves in the cells of the liver. Actually, the Kupffer cells deliver them to the hepatocytes, and within the hepatocytes there will be further growth and multiplication into a hepatic schizont. Once the hepatic schizont is mature in about 2 weeks' time usually, which refers to the pre-patent period, the schizont, the hepatic schizont ruptures and releases thousands of merozoites, which are colored in green here, and those merozoites go to infect red blood cells. Now, the merozoites within the red blood cells develop into a ring stage initially. Whatever the species is, they all pass through the early ring phase, and then that ring starts to enlarge into a trophozoite, a late trophozoite, which divides as well. And then would have the blood stage schizont, which when mature, the RBC will rupture to release more merozoites. Merozoites don't go back to the liver. The liver is only infected by the sporozoites deposited by the mosquito, and those cycles keep on recurring in the RBCs every 48 hours for the different Plasmodium species, except for Plasmodium malariae, which takes 72 hours. Now, some of the rings, some of those parasites in the RBCs, like the early trophozoite ring form that we see at the bottom of the picture, will develop to the right-hand side into gametocytes. Those are the pre-sexual forms of the parasites. They are gametocytes, male and female gametocytes, which should be taken up by the mosquito with a blood meal to develop within the gut of the mosquito, and eventually it will be infected with sporozoites. We'll come to this in brief. Okay, this is another life cycle where you can see the changes in the gut of the mosquito. Okay, I'll go over that. Here we have got a nice picture of the sporozoites in the saliva, or in the salivary gland of the mosquito, of the Anopheles mosquito. Notice how slender they are, so they can go down the tube-like proboscis or the straw-like proboscis, the mouthpiece of the mosquito. And this is again the life cycle, and here we have got the pre-patent period in the liver. It is, as you can see it, fairly self-explanatory. Okay, this is a rare picture of a pathologic section in the liver. The dots that you see scattered here and there are the nuclei with the nucleoli of the hepatocytes, and in the center we have got a hepatocyte that is engorged with a structure in there, which is actually the collection of merozoites within that hepatic schizont. This is an incidental finding on a pathologic section. That's why we say that it's quite rare, actually. Okay, now, the invasion of the RBC, the invasion of the red blood cell is not a random process where the merozoites bump into the red blood cells. No, on the contrary. Like you see here, and you start from 1, 2, 3 up to 6. Here you see docking, which means that the merozoite touches the red blood cell like a ship docking at the port, and then it reorientates itself so that the apical complex, if you remember, those are apicomplexan parasites, so that the apical complex will attach itself to the membrane and it will secrete the substances which are in its apical complex, whatever they are, and this will help it burrow into the RBC to go inside. And you can see number 6 and number 7, the merozoite has deposited itself eventually inside the red blood cell, and within a membrane, within a cover, which is the membrane, part of the membrane of the RBC, and we call that a parasitophorous vacuole. parasitophorus vacuole. So those are the stages. The malaria parasite stages in man. First, the sporozoid. Then we have the hepatic trophozoid or hypnozoid. Hepatic schizont with merozoites inside, which rupture to invade the RBCs. Now, in the erythrocytes, the ring stage, then a trophozoid, and then it enlarges further and divides into a schizont containing merozoites. Some gametocytes and a few erythrocytes will develop like that. Those have to be taken up by the mosquitoes. There is one word here in number 2, which is the hypnozoid. This just occurs with two species, Plasmodium vivax and Plasmodium ovale, where after the parasite, the sporozoid invades into the hepatocyte, it just sleeps there and it does not continue its life cycle until sometime later, let's say weeks later or few months later, it will start to metabolize and enlarge and continue the life cycle. So it will be like sleeping in the hepatocyte. That's why we refer to this stage as the hypnozoid stage. And as I said, that it is characteristic of two species only of Plasmodia, Plasmodium vivax and ovale. Malaria parasite stages in the mosquitoes, the gametocytes have to be taken up by the mosquito, and those are male and female gametocytes. They become gametes, which are the microgamete and the macrogamete. The microgamete is like the sperm actually, and the macrogamete is the female ovum, and there will be fertilization, which is like sexual reproduction, to give the zygote that we call the ookinete. Now the ookinete moves to the basement membrane of the gut of the mosquito, and there at the basement membrane it will develop into an oocyst. It develops into a cyst from the basement membrane, a cyst towards the hemocoel, not the cavity of the gut, but the other side, the hemocoel side, and that is referred to as oocyst. Thousands of sporozoids develop. Oocysts rupture into the mosquito hemocoel, and the sporozoids migrate into the mosquito salivary glands, and hence the salivary glands and saliva are contaminated by the sporozoids, and that will be or can be deposited in man again, and that completes the life cycle. So transmission is mainly by the bite of the mosquitoes, the Anopheles mosquitoes, but also there are some other species as well, not only Anopheles. Culex sometimes, some rare species may transmit malaria. Aedes may transmit malaria, but mainly it is the female Anopheles mosquito for practical purposes. Okay, now also blood transfusions in endemic area can carry malaria and rarely give malaria. Now vertical transmission from mother to child during pregnancy, this is also for congenital malaria, and it can happen in endemic areas especially. Okay, clinical features. If we look at the left-hand side, we have got the pre-patent period I told you about. This is for the maturation in the liver, for the liver stage. And then as the liver schizons rupture, then the symptoms will start. Initially, there will be flu-like symptoms, very non-specific, low-grade fever, fluctuating fever, tiredness, weakness, whatever, flu-like symptoms. Then we have intermittent fevers, recurrence of these fevers, and if the patient is not treated, then there may be central nervous system involvement, especially with Plasmodium falciparum, which may lead into coma and death. Now, chronic infection also has got its features, and relapses can occur. Now, the stages of the manifestations on the right-hand side. Cold stage, around 1 hour, the patient will have headache and will be shivering or shaking, rapid, weak pulse. And then the hot stage, intense headache, nausea, thirst, and distress. This is when the temperature goes up, actually. The patient will be cold, like chilling initially, then the temperature goes up. And then the sweating stage, which takes about 4 hours, profuse sweating, and so. This is how malaria manifests. Usually it comes at night, and the patient starts by chilling, and then there is the febrile episode, and they start sweating, and it leaves the patient in sweat and tired and weak, wanting to sleep. Okay, this is for the rupture of the RBCs and release of the pyrogens, which bring on the fever and chills and other manifestations. Acute clinical picture complications of Plasmodium falciparum other than known fever, headache, splenomegaly. The Plasmodium falciparum may produce cerebral malaria, adult respiratory distress syndrome, black water fever, severe hemolysis of the RBCs, renal failure can occur, and other complications. So, malaria is not an easy illness. It's one of the serious febrile illnesses which have to be diagnosed promptly, have to be diagnosed early and treated promptly. Cerebral malaria. What is the pathology for cerebral malaria? The changes of the consciousness leading up to coma. We have got perivascular hemorrhages, which you see here over the upper picture to the left side. Perivascular hemorrhage, we can easily see the blood vessel in there and the RBCs around it. Perivascular hemorrhages, and in this autopsy finding numerous small hemorrhages of the gray matter. Also, they don't show very well, but there will be multiple tiny hemorrhages that account for the diffuse total brain involvement and coma of the patient, the depression of the consciousness leading into coma and death. Sickle cell anemia and thalassemia. Now, any congenital hemoglobinopathy, hemoglobinopathy is relatively protective against malaria. Now, how is that? You know that the malaria parasites invade the RBCs, and actually they feed on the hemoglobin. Now, as they feed on the hemoglobin, they eat up the globin, the protein part of the hemoglobin, and then the heme, which is the iron, they get it, and with a help of an enzyme that they have called heme polymerase, they stack it aside in a certain compartment aside. Now, as the malarial parasite knows very well how to eat the normal hemoglobin, but once the hemoglobin is congenitally affected or abnormal, then it does not eat or invade the RBC efficiently. Hence, there will be relative protection in people with congenital hemoglobinopathies against severe malaria, against the invasion by the malarial parasite. So, relative protection. So, this is it. Sickle cell anemia or thalassemia or G6PD deficiency can confer relative protection of the child or of the individual against severe malaria. So we keep this in mind. Now, as an example, if you take the child, if the child is normal without any protection, as I told you, in the first few years of life, between 2 and 5 years, the child, if they get severe malaria, they would succumb to it, like you see over the left-hand side. If you come to the right-hand side, also children with sickle cell disease, that is the homozygous disease, then they may succumb to sickle cell disease or its complications as well. Whereas if the child has got a sickle trait, heterozygous, then they will be relatively protected against malaria, and also they will not get the full manifestations of sickle cell anemia and disease, and hence they can survive and carry on with their life. Thereafter, after the age of 4 or 5 years, they would have their own experiences with malaria, and they build on their own immunity, which carries them on through life. Okay, like you see here, I shall leave it up to you to read. Well, why not read it for you? In endemic areas after early childhood, most of the children, like you see in this picture, and adults would have malaria parasites on board, but it does not manifest clinically. They remain largely immune and healthy looking. Like you see here, those children are fairly healthy looking. If you compare them to a picture of malnourished children that you would have in mind actually, no, those children look fairly healthy. Also, again, those are relatively healthy children in the Amazon basin. Actually, this is the bed of the Amazon River, but this is in the dry season. So they come down to play in there. Otherwise, when the high season, when the flooding season comes, they have got to go up there into their homes and this will all be flooded with water. Now, malaria and pregnancy, parasitemia is more common, plus placental involvement in pregnancy. The disease is more serious and tends to be more complicated, and hypoglycemia is common in pregnancy as well, with or without quinine treatment. In the past, they used to believe that quinine may predispose to hypoglycemia, but actually it was found whether with a quinine treatment or without that, hypoglycemia may occur. So, as you see on the upper picture to the right hand side, malaria and pregnancy are mutually aggravating, which means they make each other worse. Malaria clues for diagnosis: laboratory, thin and thick smears, antigen capture, enzyme immunoassay, etc. Clinically, we have got the clinical manifestations, which are usually regularly intermittent fever, like every 48 hours, whenever the infection becomes synchronized, as we say. Yani the RBCs would be infected around the same time and they would rupture around the same time. This is when we would start to get regular intermittent fever, usually about 1 to 2 weeks into the illness. With normal white BC count, but thrombocytopenia, low platelets is a good clue to malaria actually. Anemia is fairly common with malaria, and splenomegaly is fairly common as well. If we go up to the laboratory, we have thin and thick smear that I shall describe to you. You know that in the laboratory what we do with malaria is that we do a finger prick. Why? Because it is better to get a peripheral blood film, not from a vein, from a large vein like the antecubital vein. Well, whatever. So you get a peripheral drop of blood by needle prick, by finger prick. You put it on the slide, and then you either smear it like you see in the lower panel, and this will give you a thin smear, or you may, with the edge of the angle, the edge of the another glass slide, you widen that spot of blood and you leave them to dry and stick to the glass, and then you can stain them and look at them. Okay, this is a schematic drawing that shows you the thick malarial smear actually, and a true picture of a thick malaria smear. The dark structures that you see up there are the nuclei of white blood cells, and then you can see the malarial parasites, the rings of malaria parasites, which are scattered around. Probably the most typical of which is the one which is at the lowermost side of the picture. There you can see a dot which is dark in color, and then a lighter yellow around it. Those are the rings of malaria. Well, the thick smears are to rule in or out malaria, but you cannot speciate it well. It takes a little bit longer from one day to the other, but it is very helpful to suspect malaria or to make sure that there is or there is no malaria. But to speciate it and know what we are dealing with, we have to go to the thin smears. And as you know that with the thin smear, we go to the single cell layer of cells and we look at them, and here you can see it. The rings of malarial parasites. Okay? You can see them inside the red blood cells. They are well stained. We have differential staining, and in laboratories, technicians are very good at performing these, and sometimes we have to repeat the smears and the stains so that we can get a clear picture, and you can look carefully and find it. Those are the rings. The dot is the nucleus, and the circle of the ring is the cytoplasm of the parasite. Okay. Again, over the left-hand side here, we can see the rings of malarial parasites. Now, this is a heavy infection, which usually indicates Plasmodium falciparum, but also the gametocytes are banana-shaped, like you see here. Now, those banana-shaped gametocytes, which are within RBCs, actually, within the red blood cells, and sometimes they eat up the hemoglobin, they eat up the contents of the red blood cell, and then they will be simply covered with the red blood cell membrane. منبطل نشوف الريد بلاد سيل بس بنشوف الجاميتوسايت لوحدها. It's banana shaped, it's typical. يعني for somebody who is not expert in laboratory like me, I can identify the banana shaped gametocyte. But it is not easy for me to identify the gametocytes of the other three human malarial parasites. Okay, this is schematically some interesting features that you can look at, but you see the schizont of Plasmodium falciparum is not drawn here. This is because we should not find it. Yani usually we don't find it on a peripheral film, peripheral blood. Why? Because the parasitized red blood cells, to develop into schizonts, they usually go to the deep circulation, they home onto the deeper organs, especially the brain, where they block the capillaries to produce perivascular hemorrhages maybe, or also block the capillaries for schizogony, where the schizonts occur. So the absence of schizonts on a smear with evidence of malaria is a 0.4 Plasmodium falciparum, whereas with the other species, you can find schizonts as well in the peripheral smear fairly easily. Okay, this is schematically a very nice picture from the atlas where you can distinguish those. You are not responsible for the details, just for your information. But if you look at the gametocytes in the lower panel, actually, you notice that the gametocyte of Plasmodium falciparum is the only one which is banana-shaped. The others are rounded, and they would need an expert to identify them from each other. Again on this chart as well, now you can understand most of it, but the dots in the Plasmodium vivax and Plasmodium ovale, those dots in the cytoplasm of the infected RBC, those dots are Schaffner's dots. So those two species, Plasmodium vivax and Plasmodium ovale, will produce dots in the RBC cytoplasm, and this is indicative of this kind of species, either vivax or ovale. Some other distinguishing features as well, which you are not responsible for, don't worry. But I would mention here that also Plasmodium vivax and ovale have got the hypnozoid stage, which we have mentioned before. Antimalarial drugs. Now we come to treatment and prophylaxis. What are the drugs like? They are like chloroquine, quinidine or quinine, tetracycline, clindamycin can be used in combination with the other drugs, mefloquine, lariam, new drugs, artemisinin derivatives, and this is very important, Malarone, which is a fixed combination of proguanil and atovaquone, and this combination is a relatively new combination and it's very good, very safe. Primaquine is also against the hypnozoids in the liver. Now, chloroquine-resistant Plasmodium malaria, the first-line treatment. Here we have artemisinin derivative combinations. Please, this is the drug of choice, artemisinin derivative and combinations. You see, in combination with something else, like you shall see in a moment. Atovaquone proguanil, Malarone, is a very good drug also for treating malaria. Mefloquine, lariam, is a very good drug, plus other antibiotics, not alone. And a quinine-based regimen, a regimen stands for combination of treatment as well. Okay, malaria drug prophylaxis, I will come back to the treatment, but malaria drug prophylaxis, it can be with Malarone, and this is given daily, 1 tablet daily, 1 to 2 days before, just to make sure that the patient does not have a reaction or so, daily during the travel, and then for 1 week after. Okay, it's taken usually on the same time daily with food, and that is an ideal drug for prophylaxis actually. Doxycycline can be taken, and it is daily treatment, 100 milligrams daily, and it has to be started 1 to 2 days before, during every day, but for 1 month thereafter. Okay, for 1 month thereafter. Now, side effects which we have to keep in mind are like photosensitivity, and it cannot be given to children or pregnant women. Mefloquine for prophylaxis can be given, and this would be given as 250 milligrams weekly, actually, every week. And you start it 1 to 2 weeks before, again, to make sure that the patient does not have reactions and is tolerating it well. And then weekly during the time of the travel, usually for several weeks or several months, whatever the patient is spending there, and for 1 month thereafter, Now, the side effects of mefloquine, usually minor like nausea, dizziness, dreams, and rarely neurologic, anxiety, seizure, hallucinations. It's contraindicated in patients with active or recent depression as well. So seizures and depression are like contraindications to mefloquine, Lariam. Okay, mefloquine resistant malaria. Now, mefloquine, before the artemisinin derivatives, used to be the drug of choice in treating resistant malaria. However, there is mefloquine resistant malaria, especially at the border between Thailand and Myanmar and Laos in that area. Okay, now this is from the up-to-date, and this is the artemisinin combination therapy. As we said, that this is the #1 treatment in severe malaria, and here we have got different combinations, the most common of which and the most widespread is coartem, artemether lumefantrine, coartem, artemether lumefantrine, this combination, coartem. Okay, other drug regimens here, as we said, number A is artemisinin combination therapy, and then other alternatives, atovaquone proguanil, Malarone, as I said, is a very good drug. Then we have got quinine plus something else, but this is being depleted or deleted from the treatments, and mefloquine can be used with other antibiotics. Plasmodium vivax and others, if sensitive to chloroquine, we can use their chloroquine or hydroxychloroquine. You know that there is a big hype now about hydroxychloroquine in COVID-19. Parenteral regimens for treatment of severe malaria, and here we have got #1, the drug of choice is artesunate. This is given IV or IM. Artemether also can be given intramuscularly, and then if we don't have artemisinin derivatives, we would go to the good old treatments like quinine or quinidine in combination plus one of the following, doxycycline or clindamycin. Of course, as we cannot give a tetracycline for children or pregnant women, we combine it with clindamycin usually. Okay, here it shows us some oral regimens for completion of treatment for severe malaria, to complete the treatment after the intravenous treatment. Again, coartem would head the list, and this is very useful. Don't worry about details. I'm giving these to you as examples for you to know what is usually the drug of choice for treating malaria. Okay, now oral regimens for treatment of Plasmodium falciparum malaria in pregnant women. So we have got to be careful here. The first trimester, second trimester, and any trimester, don't worry about these. But again, you know that artemisinin combination therapy features very well in here. Quinine with other things, definitely clinda and not doxycycline features. And those are, so in pregnant women, we have got to pay special attention. And don't worry about those tables, because they would change from time to time. So at the time you come to diagnose and treat a case of malaria, you have got to check with your references and give the up-to-date treatment to the patient. This is a picture of coartem. Okay, and prevention and control, it's something that we have mentioned before, especially with the vector-borne diseases like with mosquitoes. So avoidance of the mosquitoes by using bed nets and long-sleeved clothing and insect repellent on the exposed areas of the skin are all helpful. Drug chemoprophylaxis has to be given as well in endemic areas. Anybody traveling into the tropical countries should have malaria prophylaxis. And let me ask you a little question. They should have an injection, vaccination against another disease which is prevalent in the tropics. The two most important diseases in the tropics are malaria and that disease which I leave to you. We can talk about it in our TBL session tomorrow, if you remember. Now, removing breeding sites, larvicides, and insecticides, of course, can be used to control the mosquito population, but you know that this cannot be done easily in the tropics, maybe. And vaccines are still experimental and in studies only. Okay, تفضلوا على الموز هلا. All right.